and a PhD fellow through UCT, the Division of Orthopedic Surgery. As you know, we're going to be talking about violence in traumatic injuries today, so I thought it would be important in South Africa to talk about the role of our role as surgeons in the management of patients who come with intimate partner violence, who present to us with traumatic injuries. So I started by just reviewing the statistics first, and it's alarming to see, well, sort of expected this, but to note that 35% of the women worldwide, according to the World Bank, have experienced some sort of physical or sexual violence from their partners, and 38% of the murders against women are actually committed by their partners. And these figures are not very different from those presented by the World Health Organization. And in this particular report, where they looked at women between the age of 50 to 49, 27% of them, they have experienced some form of violence from their partners. And locally, the Stats SA reported the findings in 2019, and they found that of all the women that presented with trauma to the healthcare establishments, 15% of those traumatic injuries were in the hands of their own spouses or partners. Looking more closely into the studies, I mean, these headlines, we're used to these headlines by now. We see these headlines every week in our country, every time we watch the news. So looking at the studies that really reported on this locally, Childsafe found that 1 in 4 women in a community-based study in Eastern Cape, 1 in 4 women had a history of being assaulted by their partner, and 35 to 60% of the women who having been injured during that assault reported an injury during the assault incidents. Same figures were presented by, or similar figures were presented by girls, but I think what I found interesting here is the misconception that only females are victims of IPV. And see, the figures are not, although they're significantly higher in female compared to males, but also quite a lot of males experience intimate partner violence in the hands of their partners. And they went further to look to interview the perpetrators. 25% of women in those who were interviewed, they reported to be perpetrators of intimate partner violence. So intimate partner violence it goes both ways, and if there's even more studies showing that it does not matter whether you're in a heterosexual relationship or in a homosexual relationship, the figures are the same across. But if you look at the literature being presented among the trauma patients that sustain IPV, or they sustain traumatic injuries secondary to IPV, the literature being presented is actually from the first world countries, and there's literally nothing that it comes from African continent. Or the ones that have been presented from the first world countries, they report the incidence of between 12 and 35% among the traumatic patients admitted in hospital to be having sustained the injuries because of the IPV. So I think it's important to note that us as Africans, we probably seeing a higher numbers than the rest of the world, but we really not reporting on this, and it's important to report on this because once we start reporting on it, you can see the burden it creates on the healthcare and on economy, and we need to do something about it. And I'm sure we all agree that we need to do something about IPV as healthcare workers and as surgeons. This, the pre-study, I think this was the biggest studies among the biggest study among orthopedic surgeons and orthopedic patients done in Canada. And although we'll think that IPV, every time we think of IPV, we actually think of physical assault, but actually, if you look at the figures there, most of the patients reported to emotional abuse at 30%. Compared to only 8.5% with physical abuse. Those who present with physical abuse, if they went on to look at the patterns of the injuries, I would have thought most of them will come with musculoskeletal injuries, but funny enough, most of them present with head and neck injuries. although from the pre study they noted that most of these patients presented to the rehab centers and they were usually they used some form of substance or drug or alcohol. So most of them presented to the rehab centers, but those who presented to the hospitals, most of them presented to the orthopedic department. And there's still others who present with other problems instead of the injuries they sustained, and those injuries would be picked up when they present with other problems like those who present with in internal medicine. And I think it's important to note that also there are a lot of patients that present to ONG, and most of the patients who present with injuries in pregnancy, most of the time has been found out to be as a result of intimate partner violence. So why is it important for us as surgeons to really be involved in this? I mean, the consequences of intimate partner violence are far-reaching for the patient. And this study in 2004, they actually looked at the direct effects of IPV on the patient and the indirect effects of IPV on the patients who presented with traumatic injuries. Of the patients that presented, 30% of the patient that died from traumatic injuries, 30% was as a result of IPV. The patient that experiences IPV, they have up to 3 times or almost 4 times chance of becoming disabled. And there's 67% of them had traumatic brain injury, although only 30% of it was associated with the loss of consciousness. And 40 to 60% will have other injuries elsewhere in the body. They went on to look at the indirect effects of IPV and how they did this here. They interviewed the victims themselves, and the victims reported poor general health following the IPV. Most of them gained weight and developed lifestyle diseases like diabetes. They had poor mental health, and most of them reported poor sexual and reproductive health. We busy with a study, one of our med students at SMU is busy with a study also looking at admitted cases with IPV at our hospital. And I think this is just a preliminary results from the study from 2021. Of all the patients that were admitted, 6.1% of them were because of IPV. And you can see the distribution of the injuries. But I think what is important from this preliminary result is that you can see the force that is being used against this patient. It really must have taken a lot of force for this patient to end up, for almost 70% of this patient to end up with fractures. And we had 2 patients dying from these injuries. And the first one was a polytraumatized patient. I mean, you can imagine for it to have multiple fractures, you need high force. And the second one had a spine injury, a high spinal injury for that matter. We can't just continue as it is, and we treat patients. We treat the injuries instead of treating the patients. I think we'll agree that we need to change the thinking of just treating the patient, and I mean the patient's injuries, and going deeper into the patient history and finding out if they're victims of IPV, and start helping the patient from there. Because we know that most of them are repeat offenders, and the patient will come back, and most of them will end up with their dire results. So I think as surgeons, we need to be active and not be passive in the approach of this. So we need to develop a holistic approach where we initiate the interview with the patient, and we do not let the patient be the one who tells us what happened. We should routinely screen the patients for if they sustain the injuries because of the IPV. And there's literature to support this, and they've noted the areas where we can improve as surgeons. So the literature shows that we need to actively screen the patients. However, screening, we need to have reliable screening tools. We need to have, after we've screened this patient and found the problems, we need to have preventative intervention. So we must do research to help us in how we prevent for this and how we intervene. We need to introduce formal training for surgeons and undergraduate, and probably for all healthcare workers on dealing with patients who are victims of IPV. And with all this, we can be able to influence policy and legislature and manage the stigmas. And just looking at the screening, you can see, clearly look at the patients that at their center, if they they had a screening protocol, and when they didn't have a screening protocol, so they looked, when they didn't have a screening protocol, they were only able to pick up 5.6% of the patients as being victims of IPV. But once they introduced the screening protocol, they were able to pick up 30%. And just going back to our results, where we only have 6.7% in our results, that was my thought also, that probably we're missing more patients because we don't have a screening protocol in our hospital, and probably our numbers may be as high as probably even higher than seen everywhere. But the more studies I went on to look at what are the barriers to screening a patient, and one of such study was the PRAISE study. The surgeons themselves reported lack of time or lack of training. Some reported that they were afraid of offending a patient, or they just felt discomfort. But I mean, if you know about the 50 reasons not to change, you will know that you will see that these are just excuses. And if you can find 50 reasons not to change, surely we can find other 50 reasons why we should change. And I think that the figures I've given at the beginning of this presentation surely are enough reasons for us to change and remove these barriers. So looking at the screening tools, there is no clear literature on what screening tools are more reliable, but these have been suggested. In Bandari's study, they noted that we can start screening the patient just looking at the pattern of the injuries. So one of two patients that come with an IPV, they pretty much had a history of IPV previously, and then the patients tend to be withdrawn or have emotional or psychological problems. Those who present with musculoskeletal injuries, they usually represent musculoskeletal injury represent the second most prevalent manifestation, but they usually will come with the injury or with injuries at different stages of healing, just like we see in children who are physically abused. They represented this signs of domestic abuse, and I think what was eye-catching for me here is that trauma in pregnant patients should be screened for IPV until proven otherwise. So, but for us to improve those screening protocols and improve our way of managing this patient, we need to do more research. And in their report, the World Health Organization, they suggested that we should start looking at preventative research and intervention research. And this, they say, is instead of the preventative research, rather focusing more on the victims, let's rather focus more on the perpetrators, because we need to prevent them and potential perpetrators, because we need to deal with them from committing this kind of assault in the future. Whereas the intervention report should also examine the potential harms of the interventions that we give in hospital, like when you scare the patient and the patient never comes back. The PRAISE study and other studies, they want to look at what are the misconceptions. Why are the surgeons and the doctors, healthcare workers in general, why are they not really actively managing these patients as they need to be managed? And they found that there were a lot of misconceptions. I'm not going to go through all the misconceptions, but the one I highlighted in yellow, I found it. I have no words for it. But surgeons believe that battered women must derive some satisfaction from being abused. I'm sure there's no one would have any form of satisfaction from being abused. So we'll always have excuses for not doing things, and that for me just sounds like an excuse. If you look at the legislature from South Africa, also this is not enough, because the South African law does not oblige us to screen the patients for IPV or to manage the patient for IPV. It is just suggestive that we should, and I got this quote from this article, and what they say, it does not impose any positive legal duties on healthcare providers to screen the patient or refer the patient for holistic management. So there's still a loophole in the legislature, but even though there's a loophole in the legislature, there are guidelines from HPCSA, and these guidelines, they make it our responsibility to screen the patient, always assess the patient for the risk, to support those who need help, and to always document this, because we know usually this patient will present with other injuries in in the future. So even though we are not obliged by the law to screen for this patient, but I think the duty is in our hands to screen this patient and to help these patients because we see a lot of them. So in conclusion, I think if we can find 50 reasons why we cannot manage these patients appropriately, surely we can find 50 other reasons why we should screen all the trauma patients for IPV in a country where every week in the news we have a woman killed by their partner. We surely have enough reasons why we need to start doing research and influencing policy, and more importantly, influencing the law and the regulations provided by the council. And I think us as local secretary, this is our responsibility to pioneer this forward. Thank you.
Thanks very much, Archie. Those statistics are just awful and totally shocking. And it's hard to imagine that, you know, up to 1 in 3 of the patients that we see are being abused. I mean, I'm kind of floored by that.
Yeah.
Sithombo, while you get ready, I'm going to ask if any of the, as I understand, Archie is eager to get to another commitment. Does anyone have any questions, comments, or feelings from talking about? Yeah, okay, so I can see Salome's hand up. Go for it, Salome.
Thanks, Archie, for an excellent talk and very compelling. Mine is just a comment, and I mean, I like the slide where you're showing how they present to the different disciplines. In gynae, we've often seen them, but it's because of the association with sexual assault. But then we've always, I think, the question about what happens to those that don't have sexual assault linked to their injuries. So it's quite, obvious that it's being missed because there isn't routine screening.
True. I mean, for us, we never used to screen them. We only started screening them now when we're doing the study. We never used to actively screen, and we were alarmed to see how many of the patients that are sitting in our ward as a result of IPV.
Sure.
Can I just maybe add a comment as well, please? So I mean, thank you for that presentation, Archie. And I think for me, it's very important that, you know, we as surgeons are involved, you know, because there's definitely a shift towards more awareness about, you know, factors that just beyond fractures themselves. And what I always find amazing is that when you go and see a patient, you know, after greeting them, the first question that you ask the patient is, "Oh, you've fractured your left radius. What happened?" And then someone says, "Oh, yeah, my boyfriend kicked me." And then that's it. And then we just shut off completely and say, "Okay, fine. You're going to need a plaster cast and operation." And yet you've just received this very powerful piece of information that you've firstly asked for, and you've been given the answer, but then you ignore it completely afterwards. You know, like as if to say that's not my problem. So I think it's just something that, I mean, I'm happy to see the awareness from the surgeon's perspective. Thanks.
Archie, do you want to respond?
Yeah, I think how our boss does it, and I think from our department is one person who's getting it correct. When he does his ward rounds, he has everyone in the ward round, including the psychologist and the social worker. And once the patient reports such a kind of thing, then the social worker and the psychologist are there. But I think we also need to get involved as surgeons, instead of just kicking it back to social workers and the psychologists sort this out. We really need to also get involved in the management of this patient holistically. We can't just want to go and operate or treat the fracture when the patient has a problem.
Yeah, I mean, I think one of my questions is, I'm not a surgeon, so my question is, how do we equip people to answer that question better? So when someone, you know, so how many of our surgeons, how many of our general medical practitioners get recurrent exposure to training about how to respond to a disclosure? And in some ways that needs to be protocolized. If you think about some of the other things that we breaking bad news. There's training for that.
I think we need to formally introduce this in the curriculum. As far as I can remember, undergraduate we were being taught this, but postgraduate, no one ever mentioned anything about IPV anymore. So even in the postgraduate curriculum, I think we need to introduce training of the students about IPV and how to manage the situation.
Totally agree. Stanley, I see your hand. Would you like to ask a question?
Yes, absolutely. Thank you. After everyone, my name is Stanley from Kenya. Thank you, Archie. That was an interesting presentation. I am wondering, evidence to show that what are called one-stop centers or gender-based recovery centers, gender-based recovery centers, that the pickup might be better and the care might be a little more coordinated, not just the physical care, but the legal perspective, the mental counseling perspective, and taking care of these people, especially post-trauma care and follow-up. I don't know in terms of the arrangement of South Africa, do we have any gender-based violence recovery centers, because they kind of tend to play a good role in sensitization and following up and linking up and, tagging into the criminal justice system so that the perpetrators are tracked beyond the hospital premises. I don't know how they experience this in South Africa. And if there are facilities that have such centers, is the pickup better in terms of whether or not there is a screening tool?
Thank you, Stanley. But yeah, I think that's it. I don't know about if we have such in South Africa or in my area. But also, I think for them to end up in that center, they must have been screened and picked up early on, and I think that's where we're really missing it. We're not picking them up early when they present. I don't know if you guys in Kenya you do have any screening protocol that obliges healthcare workers to screen the patients as they come in. Because I think that's where the initial problem is. Because once we've picked them up, maybe we're not doing enough, but there's always something getting done for them.
All right. I'm not seeing any more hands. So before we move on, there was just one piece of research that I wanted to tie in, which was there was a wonderful paper that came out of the Curtis Care Pain Clinic a year or two ago, which was about linking trauma, so like emotional trauma, history of depression and abuse, to long-term chronic pain and lessened recovery. And it'd be interesting to see, so that's another aspect of abuse and surgery, is it's likely to actually affect their experience of their recovery as well. Archie, thank you so much for your wonderful presentation. It's lovely to see so many questions and engagement. Prof. Sithombo, are you ready to take it away?
Yes, I'm ready. Thank you. Thanks, Joe. So listen, firstly, thanks once again, Archie. We have had discussions with Archie outside of this meeting, and we're going to continue the discussions afterwards. There's a lot of work that needs to be done, and lots of potential for collaboration, so thanks, Archie. I'll catch you in the other meeting. Alrighty, so let me share my screen. Just 1 second, sorry. Okay, please confirm if you can see my screen.
Yes, we can.
Can you see my screen?
Yes.
Yes, okay,
Yes.
Thank you. Alrighty, guys, so thanks once again for the opportunity to present to you this afternoon. So I'm Sithombo Maqungo, and I am an orthopedic trauma surgeon at Holiskia in Cape Town. So as is customary, so these are my disclosures. So I have no financial disclosures, But I want to declare upfront that I do belong to some injury prevention organizations as a board member for Childsafe, as well as Gun Free South Africa. I'm also the founding member of the UCT Trauma Advocacy Group, and also collaborate with the Southern African Alcohol Policy Alliance. So if you sense some biases in my talk, it's because of of my affiliations. So I live and work in Cape Town. For the people that are not joining us from the beautiful city, that's what the city looks like. And in the corner there is where our hospital is situated. It's the most beautiful city in the world. And it's not just me saying that. It's been voted as the most beautiful city on countless occasions by multiple different magazines and travel websites. And even the Americans that never travel also rank Cape Town quite highly. So if you've never been, please make a plan to come and visit. So of course, we've got this accolade of being the most beautiful city in the world, but we have another reputation, and that's being the world's most dangerous city, or the deadliest city in the world. And of course, this accolade is not, necessarily wrong. It is based on figures. And if you compare us, as a country, in terms of the most dangerous places to live, we are number 2 as a country, but remember that I'm talking about Cape Town specifically, which has got even higher murder rates. And if you look at the numbers, at the countries on the left, what you see is that the countries which are most dangerous also are the countries with the highest Gini index. I'll speak about the Gini index a little bit later. But basically, inequality leads to crime, and that we know. So I've given you, the background to that. But if we come to Cape Town itself, so our, homicide rate is 65 per 100,000 people per year, and the global average is a tenth of that. So that's 6% 6 people per 100,000. And just to compare, because we always compare ourselves with the best cities in the world. So the homicide rate in Amsterdam, which is on the rise in terms of the numbers in Europe, is only 2 people per 100,000. So we are 30 times more deadly than Amsterdam. And like I said, as a country, South Africa is 35, but Cape Town doubles the murder rate. So in our country, 22,000 people are killed every year. And if you look at daily stats, 58 people are murdered every single day in the country. And of those 58 people, 3 are children, 8 are women, and the vast majority are males. And I'll show you later that these are, of course, males in the prime of their lives in terms of the age. So what's happened is that now, of late, what we've noticed is that previously you would see a patient coming in with 1 bullet wound to the body, but now it's no longer fashionable to be shot once. We're dealing with assassinations, basically. So, and of course, as part of this is gender-based violence. And I said earlier that every week we lose about 20 women in South Africa to gun violence, and multiple gunshot injuries are now more common than single injuries. This woman had 22 entry wounds into her body from her partner. If that's not an assassination, I don't know what is. I've spoken about Cape Town with our, these are stats from one weekend, but of course, this is becoming a global problem. We've seen many publications and many instances around the world now, certainly in America, where a lone gunman comes and creates carnage by shooting down lots of people. We've seen it in Europe. So it's something that is becoming a problem for everyone, and it's something that everyone needs to be aware of and certainly be able to treat it. So why are we so violent in our society, certainly in South Africa? And I said earlier that it's really got to do with inequality and unemployment. Now, because if you look at the classic trauma patient, we know that trauma is a disease of the poor, it's a disease of the disenfranchised, economically marginalized, poorly educated, and just downtrodden. I'm lucky enough to work in both the public and the private sector, and the kind of injuries you face in the public sector where people are, tend to be poorer versus the injuries in the private sector is completely different. So trauma is a problem in unemployed people, uneducated. And of course, the other difference within our country is that we've got this stark divide between the rich and poor, but most of the time they live side by side. So it's not like you have to travel like a long distance to go and see the poor part. Like the inequality is visible, it's in your face, and it's offensive for lots of people, and it leads to lots of anger as well. So if you look at the trauma epidemic, so I said this is how the countries rank by inequality. And this is one of the graphs that we top in the world. And it's a graph that measures the Gini index, which is the difference between the rich and the poor. And it's a map that or a graph that you don't want to be first on. And again, if you look at the countries represented there, those are the countries that also have a homicide problem. Now, this is a map of the world as you know it, and now every country here is represented according to geographic size. But if you look at other indices, and certainly if you look at the number of violent deaths around the world, then the map of the world changes completely. And you see where the deaths are mostly located. It's in South America, mostly in Africa, and some bits of Eastern Europe and a little bit in Asia. But of course, the irony here is that most of the research is done in the first world countries which don't have this problem that we have. So it's an opportunity for clinicians and scientists and researchers in the global south, so to speak, to be more involved in certainly sharing and leading on the information and knowledge creation, actually. Now, who typically gets shot? So 98% of them are males, and it's a young male, mid-20s, and these are individuals in the prime of their lives. And the economic impact is massive because this is someone who is then removed from the formal or informal economy. They then rely on the state system, firstly to treat their injuries, but also now to look after them in terms of welfare afterwards. And most of the time, I'll make an example with someone who gets shot and gets paralyzed, then they're going to be dependent on the state for the rest of their lives. And often, if they need full-time caring, one of the caregivers, often it's the mother who then gives up her job to then look after the injured son at home. So that's one more person who has been removed from the, from being active in the economy, and also relies on social services. So the cost to the fiscus is massive. Now, if you look at the violent deaths, 45% of them test positive for alcohol, and these are deaths from the mortuary. 40% of trauma patients that come into the hospital who have sustained violent trauma also test positive for alcohol. And I'm not talking about just positive, but high alcohol levels. And more than 2/3 of the incidents occur between Friday and Sunday, and there is a link between alcohol, violence, and of course most people are in the informal sector, and many of them get paid on Friday. Now they take the money and then go drinking. So we have a trauma problem, yes, but we also have an alcohol problem. So this is now where the need for some regulation or alcohol control becomes important. So if we look at the top 10 instruments used in murder in the country, you can see firearms are 7,000. So these are cases from SAPS. Probably 5-10 years ago, it would have been knives, but certainly in our trauma unit, you hardly see a patient that's been stabbed. It just doesn't happen anymore. People come with firearm injuries. And that's with good reason. Why are guns so desirable? Because they are small, they're light, they're easy to use, importantly, easy to conceal. And you don't have to get down and dirty, with your person that you are attacking. You can do it from a distance and keep your hands clean, so to speak. And importantly, also the outcome, is, if your intention is to kill, you are 18 times more likely to kill your victim with a firearm than with a knife. And 1 in 3 people who have been shot will die. And this is in contrast to 1 in 50 who have been stabbed will die. So if you want quick and instant results, the firearm is your friend. And so we'll talk about these firearms, and of course we refer to them as illegal firearms. But this is a bit of a misnomer, because when you say illegal firearms, that's often really firearms which have entered the country illegally, and that is only like very few firearms like that. Most of the firearms that we call illegal were firearms which were once legally owned by somebody, and they get taken away from that person. So the gun was issued legally, but now it finds itself in the illegal market. And so that's the biggest source of firearms in the illegal market. It's theft from police officers and theft from civilians who bought the firearm with the intention of protecting themselves. Which then brings us to another discussion, the importance of firearms for protection or for self-defense. So if you take, as I said, these are states from the US, and the title of the article is it for protection or for peril? That, so 57% of firearm deaths in the states were self-inflicted. So it's someone who bought a firearm to protect himself or herself, but more than half of them end up using the firearm to injure themselves or to kill themselves, which begs the question, like I said, is it protection or peril? And again, if you buy a firearm or if you obtain a firearm with the intention of protecting yourself, the stats have shown that you have 8 times higher chances of having that firearm taken from you than you using it in self-defense. And the other bit that's misunderstood and often misquoted when people say, no, I want a firearm for self-defense. Most of the time they refer to defense of property, because if you ask them, what do you mean by self-defense? If someone comes into my house at night to rob me or to steal my stuff, that is not self-defense. That is defense of material possessions. Because if someone walked into your front door to steal your TV and you went out the back door and let them steal the TV, there is no harm that will happen to anyone. There's no reason for anyone to get injured, but it is the presence of a firearm in any interaction that increases the percentage or the chances of death immediately. So it's not often used, like I said, for self-defense. It's used, for defense of property. And, many places that most people would be vulnerable in, like when you go out in public, when you go out into shopping centers or shopping malls, actually that's where you're probably most vulnerable, and those places don't accept firearms. So you're not allowed to take a firearm into a sports stadium or into a shopping mall or into a restaurant. And then when you're at your home, that's when you're at your safest, strictly speaking, and that is where you actually don't need to have a firearm. So now, how do people get injured? Typically it's interpersonal violence, and it's people who have been sitting and drinking or arguing together. So it's often arguments, misunderstanding, and you always ask someone, who shot you? Oh, my friend shot me, or like, what happened? No. We were either in a spaza shop, in a informal drinking place, or they were in a tavern, or they were drinking in someone's place. But it's almost always, it's interpersonal, and it's people who know each other. It's very rarely that it's going to be, an unknown person with a firearm injury. And of course, there are other things like detective violence and armed robbery, but those are not that common. So what this shows is that nearly half of all assaults are committed by someone close to the victim. It is not often a total stranger. It's going to be someone that they were sitting and talking to. So now, if we look at, these are like, horrible stats. Over one weekend in Cape Town at 8-hour hospital, these were the number of admissions. Bilateral femur fracture, forearm, upper limb. We've got forearm, femur, another femur. So it's not normal to have these injuries. And, for a country not at war to lose 30 people per day to firearms is unacceptable. And it is just abnormal, but we've normalized an abnormal situation. And I've picked just 2 wars just to make an example with. So the recent war in Afghanistan that the US pulled out of, they lost, 6, and so basically about 10 people per day over 20 years. Only 10 per day, and the Americans deemed this war unwinnable and they pulled out. That's 10 a day in a formal war versus us, 30 people a day, and we are not at war. These are just all civilians. Another war is also 20 years in Vietnam, where the US, in a full-blown war, they lost 8 soldiers a day, and they deemed this war to be unwinnable, and they pulled out. And again, compare 8 soldiers a day versus 30 people a day for us. So just to emphasize, like I said, it's an abnormal situation. Now, we look at, so why do some of us get involved in injury prevention? And Desmond Tutu once said that there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they are falling in. And the analogy we use in our trauma unit is that when we treat these patients, all we're doing is simply mop the floor, but the tap upstream is wide open. So you treat them, they go back to the community, they get shot again, and they come back. So we need to at least find ways to break that cycle. And of course, to control any problem, we know that first you must quantify it. We see these patients all the time. We have enough data, at our disposal. And if you look at things like infections and cancer and TB, those are notifiable diseases. So the first start would be to make gunshot injuries notifiable, just so we can make the government aware of this epidemic. And when I said these are just examples of notifiable conditions, and many of them are infections, and there's nothing about trauma. And yet, if you look at the burden of trauma, this is the slide that comes up a lot in global surgery literature, that if you look at injury, it contributes, it's responsible for 32% more deaths compared to TB, malaria, and HIV combined. But guess where the money goes to? Money goes to TB, malaria, and HIV. All the research goes there, and yet it should be more, concentrated towards injury. We've tried to quantify our burden in our own hospital with how many patients require surgery from gunshots. And, I'm also running like a prospective registry just to better understand and map a complete picture of the gunshot problem that we have. And many of the questions we ask, are quite, not many are clinical questions, because most of the clinical questions we know. We've built careers out of treating these patients. We've built academic profiles, but now we're trying to understand more where the patients come from and who they are. And like I said, we ask questions like that are not clinical, like, do you know who shot you? And many patients will say yes. And then, of course, like we ask about, belonging to a gang, all of those things. And importantly, have you reported the matter to the police? And this is where it becomes disappointing, because the answer is almost always no. Why? Because police are useless. That's often what they say. So we ran a national study a couple of years ago, just to paint, like we did like a 2-week snapshot of many centers around the country and their gun admissions over the 2 weeks. So what we found is that, again, like I said, one third are unemployed. Almost half of them have been arrested previously. So this points to the social problem. Another half have either been stabbed or shot before. And only 1/3 of the cases where the police were informed of the problem. So then it begs the question of whether there's an opportunity for social intervention, because when they come through the hospital for treatment, we know what's going to happen. Is that they're going to go back. So, like I said, some have been stabbed, some have been arrested, and they're never going to report it to the police. And of course, it's not unique. If you look at just Africa on its own and how many incidents of crime are reported to the police, well, the answer is is disappointingly low, and we're high up there on that map because our guys just don't have faith in the policing system or police service. And again, like I said, some have been arrested previously and some have been stabbed or shot or both, and we call them repeat offenders. So what do we need to control the problem? Look, I am under no illusion, it's not a simple problem to solve because it's a multifactorial problem and we're only involved as clinicians. But things to look at are, you need to look right from the start, like from early childhood development. We need to look at our education system because many of these patients have low education levels, and we know that many of them are unemployed. And if you are uneducated, you're unemployed, you don't really value your life that much. You don't value your body that much because if you get hit by a car, it doesn't make much of a difference in your life next week. Whereas if you're employed and you break your ankle, you know that you're going to lose your job. So you tend to look better after yourself if you have employment and education. We need social support programs and also justice reform, because many of the people or even the police will tell you that they're actually themselves just disillusioned because they arrest the people, but then they are released again, because there's no evidence or the crime scene was tampered with. So it's multifactorial, but importantly, it needs to be long-term. There are very few or maybe even no immediate short-term gains. We just need to commit to it and have a long-term approach to it. And like Nelson Mandela said, that safety and security don't just happen. They need to be a result of collective consensus and public investment. And this is where we all come in. And we need, as clinicians, to be involved in advocacy, because let's face it, trauma is an epidemic in our society. And it's just something that I'm hoping with this presentation I can inspire you to give more thought to what your responsibilities are. And of course, there are lots of examples around the world whereby there have been interventions. And when Colombia used to be right up there with murder rates, but they drew the line and said, what, from this moment onwards, we're going to do this, this, and that, but we want to control gun ownership. And they did that, and they've got positive results, certainly in the two most deadly cities in Bogota and Medellin. So, there is a precedent that's been set internationally, but also locally. We know that when the Firearm Control Act, came into effect in 2004, the number of firearm injuries just went right down, because the more firearms, the more licenses you give, the more firearms are available in circulation, then the more firearms are available for theft, and the more firearms are available in the illegal sector for people to get shot with. So the way to close the tap is to reduce the number of licenses that are issued. And some of you may be aware that there's lots of discussion and public consultations now, because we, as Gun Free SA, we've reached out to the Civilian Secretariat for Police Services to remove the clause about personal protection or rather self-defense. Besides Americans, no other country in the world, certainly the developed countries, have got that clause for for gun ownership. And it's just people who like I said, mistakenly thinking that by having firearm you're going to be protected. And like I said, you tend to lose your firearm more than you will use it for protection. So we'll see what the lawmakers make of that. Of course, I spoke about firearms mostly, but of course there are many other ways to intervene. Like I said, I'm a member of Childsafe as well, and there are many programs that we've initiated, and one of them is called Safe Transport to School, where they basically take the public transport drivers for schools and install monitors and trackers in the vehicles, and you get rewarded for positive driving behavior. And of course, we all know that if you're being watched, you tend to behave well and you tend to drive well. And in the last 5 years, none of those taxis that have been fitted with a tracker have been involved in any fatal injuries, because the drivers know that they're being watched. So it's initiatives like that, that we need to think about and to incentivize people for good behavior. The same can be said for motor vehicle accidents. There are many lobby groups, and clinicians should be also involved in looking at how to reduce the number of car accidents in our society. So can we intervene? Yes, we can. We've learned great lessons from COVID-19. So what we've learned is that if the government wants to act, they do act, and they act decisively. So with COVID-19, our approach was mostly, and I say mostly because at some point the wheels came off, but the approach was mostly informed by science and by learning from other countries that were ahead of us with the pandemic. And so we know that COVID was an epidemic, stroke endemic, and so are gunshot wounds. So control of any epidemic requires interruption of the transmission vector. Whether the vector is a virus or a bullet, but that needs to be interrupted to stop the spread of gunshot injuries. So I'm going to leave you with some questions to think about. That, like, with all the information we have, certainly with victims of IPV, like, what is our responsibility towards those patients, because they volunteer the information to us? Do we have an ethical obligation to be involved in some kind of injury prevention? And there was a paper, which I cannot find now, but they argued that as a clinician, and if you're treating patients who have been injured intentionally, it is almost unethical for you to not investigate and be involved in trying to help that patient beyond just the clinical injury. And lastly, how do we shift the focus on gun violence from just treating patients in the unit to being more involved in upstream prevention? So I'm going to end it there. Thank you for your time, and thank you for your attention.
Thanks, Sithombo. So, sorry. We've got 2 minutes left. So there's just one question. If there's one more question.
Okay.
So my question is, as an area, is the lessons from COVID-19 and the alcohol bans a possible area for clinician advocacy in trauma-related reduction? Or do you think that the 2 small snapshots we have from 2 trauma centers in Cape Town are not quite enough?
Sorry, man, Joe, you actually broke up a little bit initially, so I missed the first part of your question.
Oh, I was going to say, if we're talking about what clinicians can advocate for,
yeah,
is alcohol and the link to trauma as a prevention strategy, how well do you think that's going to be received? What do you think of the research that came out during COVID from our 2 major trauma centers? Yeah,
so look, I mean, alcohol is always a contentious subject, but if you look at certainly what the Alliance has done, so no one ever advocates for complete alcohol prohibition, but there's definitely a place for better control. And there are many interventions you can introduce. For example, if you change the size of the container for the alcohol. So if you say, look, a beer can only come in a 250 can, because if you buy a whole quart, you have to finish it. Like there's no way that you can close it and put it away. And things like alcohol specials, like you shouldn't be able to buy alcohol on special, because that leads to excessive consumption. There are many things like, of course, looking at how to tax, alcohol in order to reduce availability. You can increase the drinking age. So we know that, yes, if there is a link between alcohol reduction and the reduction in trauma numbers. And I mean, I remember the first Monday after lockdown 1 was lifted, it was the busiest Monday ever in our unit, and the smell of alcohol combined with blood, it's something that actually for like 6 weeks was gone completely. And the day it came back, like, ooh, we actually missed that smell. So there's a place for alcohol regulation, but the prohibition doesn't serve anyone, but regulation, yes.
Thanks very much. Yeah, I think it's an interesting area of advocacy for all of us. So we've reached 2 o'clock. I'm gonna close the meeting. For those who would like to leave, you're more than welcome to. I see Caroline's hand, so I'm going to say thank you, Sithombo, and we're going to take one more question, but thank you to everyone who joined. If you've got to jump off to something else, thanks for joining today. Caroline, would you like to unmute and ask your question as the last question of the day?
Okay, thank you. Thank you, Prof, for such a very important talk and information. And I must say, indeed, violence injury prevention is really, really critical. Oh my goodness, most of your stats that you mentioned was quite disturbing to know that 62% of trauma epidemic in 2020 was from South Africa. And also when you mentioned that 45% of violence trauma patients has increased due to alcohol, and also obviously having an impact on the access to surgical care. So my two questions is based on, firstly, all the data that you have collected, have you had data where it showed in which areas within like South Africa, because we know that most of the violence and which is also connected to poverty, it's more in informal settlements. Especially you mentioned the age group about 25-year-olds, young adults who don't have jobs, who are in gang violence and all of these things. So have you had any data that has that kind of description? And also, have you guys talked to the government in terms of them being involved in this kind of work that you guys are doing? Secondly, what are the best interventions to reduce violence indirectly, reducing trauma injury cases within our hospitals, following some of the points you mentioned on what is required, especially for that one where you show that alcohol is a huge impact, because we did see during 2020 where lots of patients couldn't go to hospitals because now you were dealing with COVID and the high rates of increase of trauma due to alcohol.
Yeah. All right. Thanks, Caroline. So to answer your first question about where the cases come from, so the answer is, look, most of them come from the poorer and impoverished places of in around Cape Town. So there was an initiative certainly with Country SA, which was called Shot Spotter. So basically they put up sensitive cameras around the Cape, and they would register each and every gunshot that went off. And what we did with the grid study, we also did mapping around Cape Town to see where the patients came from. Unfortunately, with the grid study, we mapped the patient address, not where they got shot.
Oh.
So, but if you look at Shot Spotter, I mean, many of those firearms went off, like in the Cape Flats, Langa, Guguletu, and which closely mirrors what we see in the hospital. But at the moment, with our prospective registry, we actually ask them now for the actual physical location where they got shot, and we'll see now if that corresponds with the Shot Spotter. And then the second question, about what things we can do. Look, there are many things I think that we can use to intervene. I mentioned alcohol regulation, but other things like taking to SAPS, because if you had like an SAPS charge office in the trauma unit, so anyone who comes in and they get they've been shot, you open your case, you open your folder, everything goes together so that every single case gets reported, or even like I said, you must have notifiable conditions for gunshots. And yes, we've met with the government, and so like I said, because often what happens is that the people that make the laws but never have actual effect, knowledge of the effect on the ground. All they ever see are the number of deaths mostly, and they see this on on popular media and newspapers, but the actual impact on the ground felt by the clinicians is unknown to them, and unless we tell them about it, they will never know. So we met with them, I think about 2 months ago. They actually they came to the hospital at our invitation because they're trying to build a case to change the law. So it's nice to have, because often all they ever hear from is the gun lobby, like the right-wing gun owners, the hunters. Those are the people with the resources and the time, in all honesty, to defend their arguments, whereas most of us are just busy in the trauma units and just, like I said, working and just mopping the floor. There's no time to get involved in any of the initiatives. And yet, if our voice isn't heard, then the lawmakers will never know what the impact is.
Thank you.
Thanks.
All right, thanks everyone. Thank you, Prof. I think that was a really wonderful presentation and very informative, positive comments in the chat using words like enlightening. So thank you for enlightening us. I'm going to close the meeting now. Thank you everyone for joining. Thank you to both of our speakers for their time, and to Amy for keeping us organized and on track. We'll see you all at the next meeting. Thank you very much.
Right. Thanks,
Bye.
Joe. Bye, guys.
Bye, thanks.